countries in the Pacific and Asia are recognised for innovative food policy and settings-based approaches for protecting children against unhealthy weight gain. This session will showcase examples of the latest initiatives to promote and evaluate these approaches from across the Asia-Pacific region. My name is Colin Bell, and on behalf of the Faculty of Health at Deakin University and our Dean, Professor Rachel Huxley, it's a pleasure to welcome you to this session. I acknowledge the Wurundjeri people for their custodianship of the land that we're meeting on and their elders past, present, and emerging. This morning, you will hear about policy and setting-based approaches for childhood obesity prevention in the Pacific and Asia, and advocacy for policy action in Australia. Each speaker will have approximately 10 minutes to give a presentation, and to make this session as interactive as possible, we have time after each presentation for questions. Please use the mics at the left and right of the room here, and I encourage you even now to start thinking about one thought-provoking question that you might like to ask our presenters. Our first presenter this morning is Dr. Donald Wilson. Donald is Acting Dean of the College of Medicine, Nursing and Health Sciences at Fiji National University. He's also Director of the Fiji Institute for Pacific Health Research, or FIPA. And through FIPA, he is Director of CPOND, a WHO collaborating centre for obesity prevention and management. Dr. Wilson is a public health physician and spent 12 years in Japan, where he obtained a PhD degree in the area of occupational and environmental epidemiology. His current areas of interest are in water-sensitive diseases and re-emerging communicable diseases, sexual reproductive health, and NCDs, particularly the disease burden and the importance of policy responses. Please join me in welcoming Dr. Wilson.
Bulawanaka, ladies and gentlemen, I am Donald Wilson from the Fiji National University. Firstly, in recognition of both people and place, I respectfully acknowledge the past, present, and future traditional custodians of the land on which we stand, the Wurundjeri, Woiwurrung, and Bunurong peoples. My role as the director of FIPA also oversees the work of CPOND, as Colin had introduced, and I'm honored this morning to share with you the progress and challenges in implementing prioritized actions of the Pacific Ending Childhood Obesity, ECHO, network, for which CPON serves as the secretariat, and opportunities to enhance national action plans on behalf of Pacific Island countries and territories. And I'd also like to acknowledge especially the collaborations of Professor Colin Bell and Jackie Webster and others with Dr. Ngande Wanga, the head of our CPOND, in this work over the past decade. As Colin had also mentioned, CPOND was also very honored to have been designated a WHO Collaborating Center designation for obesity prevention and management in 2021. Which way do I point this? Is that moving? All right, sorry. So as an outline, I'll provide some background and then move on to food policy and settings-based approaches that we've done in Fiji and for the Pacific, some examples of the latest initiatives and advocacy for policy actions. Childhood obesity has become a global crisis and is a serious concern as it is reaching alarming proportions in island countries in the Pacific region. While the data in this graph is more than 10 years old, high rates of overweight and obesity are evident in adolescents 13 to 15 years in the region as illustrated, and they are higher than the global average. Recognizing the health, social, and economic burden of childhood obesity, the Pacific Heads of Health and health ministers meetings endorsed the establishment of the member state-driven Pacific Ending Childhood Obesity, or ECHO, network in 2018, and committed to support ECHO priorities such as physical activity promotion, fiscal measures, and restriction of marketing of foods and non-alcoholic beverages to children. In 2019, country representatives drafted plans of action in these three priority areas. Despite some progress, challenges remain. Since 2017, we now have 20 countries who have nominated Pacific ECHO focal points. The ECHO network partners have been expanded and now include PIHOA, or the Pacific Islands Health Officers Association, which is largely in the Northern Pacific, SPC, or the Pacific Community, WHO, UNICEF, Deakin University, the Pacific Council of Churches, the Pacific Islands Forum Secretariat, and the Fiji National University. For the first priority area, physical activity, the Pacific ECHO partners worked with the Pacific Island countries and territories to develop and implement a Pacific region-wide physical activity campaign. 15 countries completed a situational analysis of school-based physical activity. Findings showed that most countries have school-based and community-based physical activity programs. Only a few countries have media campaigns to increase awareness and have physical activity action plans running or being developed. 10 countries expressed interest in progressing the second component of the regional campaign development, that is the formative research component. This involves formal consultation with relevant stakeholders, including parents and children. 3 countries, the French Pacific territories of French Polynesia, New Caledonia, and Wallis and Futuna, have completed the formative research component. Unfortunately, the COVID-19 pandemic hindered progress on this development for most countries. Since the adoption of the NCD roadmap by the Joint Forum Economic and Pacific Health Ministers in 2014, Fiji is soon going to publish its physical activity guideline, which I have taken the liberty to show the cover page and 2 other pages shown here. These guidelines include recommendations for the minimum necessary levels of physical activity and recommendations for reducing sedentary behavior in order to improve health outcomes. And it is good to see recommended activities broken down for children by their age groups, for the under 5 and for the 5 to 17 years. This should be available soon once Fiji officially launches the guideline. Priority Area 2, fiscal measures. Taxation is the most cost-effective measure to reduce tobacco and alcohol use and is an effective strategy for shifting dietary consumption patterns, especially around sugar-sweetened beverages. Taxation is also a tool for generating revenue for the government. Despite the evidence, political commitment, and progress on health taxes vary in Pacific Island countries. Only 5 countries are fulfilling the Pacific Health Ministers' roadmap, NCD roadmap commitment to achieving a tobacco excise tax of 70% of the retail price. Alcohol and SSB taxes, on the other hand, have often decreased due to inflation on reductions designed to help consumers or businesses without consideration for the unintended consequences. Health taxes are applied to products that cause health-related harms. Health taxes must be well designed to reduce consumption and improve population health. Poorly designed health taxes will not be effective and may even be counterproductive. Due to the pandemic, many PICs, or Pacific Island countries, need to increase revenues, and making this an opportune time to develop or strengthen taxes designed to reduce NCD risk factors. And a country's readiness to introduce or strengthen health taxes depends on various factors, such as strong partnerships between the health and finance ministries, support from policymakers and the public, and the availability of international and local evidence. So these countries, sorry, I'm not sure if I can work this. Yeah. Thank you. So for the member countries on Fiscal Measure 2, in efforts to review fiscal measures on unhealthy food and beverages, member countries have collectively agreed to develop a sugar-sweetened beverage toolkit to support country-level action, building on existing materials and information. Work in this area is progressing, and partner agencies organized a taxation workshop in late 2022 to address key issues around taxation on foods and sugary drinks. Priority Area 3 on restriction of marketing of foods and non-alcoholic beverages to children. Following that inaugural meeting, member countries proposed the development of a regional toolkit to assist countries in developing national marketing regulations. The network can now utilize the recently endorsed Pacific legislative framework for NCD to guide the development of this toolkit. Additionally, countries can also utilize the WHO recommendations on the marketing of foods and non-alcoholic beverages to children to guide their efforts in addressing this issue. To provide further support, the workshop that was conducted in November 2022 to build capacity and strengthen cross-sectoral collaboration and develop a short-term plan of action to improve national legal frameworks that can support specific regulatory mechanisms for this priority area. Priority Area 4 on childhood obesity surveillance. In order to monitor the changes over time and to understand the effectiveness of interventions, the development of childhood obesity surveillance was proposed by the countries. Technical agencies have commenced discussions on developing a standardized tool that could be used for children aged 5 to 10 years of age. There are tools being developed globally, but there needs to be more conversations at the country level to introduce or strengthen monitoring systems on child growth. And lastly, in terms of advocating for policy actions, an update from the Center. A lot of the work that's been done over the years has resulted in dissemination of the information through publications. The first, in terms of protocols, the scaling up of food policies in Pacific Islands. There was a protocol paper that was published, and this has been disseminated widely. The second, on policy landscape analysis of nutrition and health-related policies in Fiji. There was a paper that looked at the overall findings, or talked about the overall findings. There was another paper that was published and comparing the political economy analysis between Fiji and Tonga. Another paper was looking at incorporating a gender lens into nutrition and health-related policies in Fiji, and just looking at what the stakeholder perspectives were through that lens. As far as the monitoring of the food environment in Fiji, there was a paper that was published, a shop survey, and looking at the packaged food supply in Fiji, nutrient levels and their compliance with sodium targets and adherence to labeling regulations. There was also a nutrition survey of 534 adults from the Central Division of Fiji that was conducted in 2022. There was also a paper on the salt and sugar intake and main sources that was accepted by the Lancet Regional Health. And this is the paper on the potential impact of salt reduction in Fiji, and I think this was greatly taken up by the media, picked up by the media in Fiji, and that was circulated in most of the government ministries. This is a copy of the Fiji Food Policy Workshop report, which only happened last month, and Colin and the others attended this important meeting. Of course, challenges remain despite these commitments, and there are great challenges in sustaining the Pacific Eco Network. Establishing the network as a country-driven platform has not translated effectively in practice as technical agencies continue to drive the plans of action. While the Pacific Island countries and territories recognize the critical point in the obesity epidemic and have made a political commitment, more resources are still needed to accelerate the prioritized actions. The eco-focal persons are overwhelmed with competing priorities. Time and financial constraints continue to hinder the progress of collective actions. And we'd like to add that these challenges were beyond Some of these challenges that you've seen, I've highlighted, were beyond our control and have also delayed the targets of our center, our research center, CPOND. And as a WHO collaborating center, that's also affected the deliverables that was expected of us as a WHOCC. But I'm hopeful that WHO acknowledges that. Carrying out these prioritized actions requires a whole-of-government approach and CSO engagement, but there is not enough attention given to this. To conclude, with the Pacific's commitment to early childhood development, ECD, greater collaboration is needed between ECD and ECHO for a more coordinated and holistic approach to delivering for Pacific children. Thank you for your time.
Thanks, Donald. You might want to stay at the mic, or you could use the one on your chair. It's up to you.
All right.
Thank you for an excellent presentation. Can I ask if anyone has a question? I can see there's a question from the audience. Over to you. Oh no, it's a volunteer standing beside the mic. No questions? In that case, Donald, I have a question for you from one sugar-growing country to another. Australia doesn't have a sugar-sweetened beverage tax, and listening to you, it just rolled off your tongue so easily. Tobacco taxes work, alcohol taxes work, sugar taxes work. Any advice for our policymakers around perhaps getting a sugar-sweetened beverage tax here?
Yeah, thanks, Colin. I don't think I should be giving you advice. But I think the smaller the countries, it's probably easier to implement these things. And also, because the Pacific Island countries are very similar geopolitically, culturally, it's, when we talk about, and this happens a lot in heads of health meetings, for instance, when we talk about something that Fiji is doing, the other countries around could very readily sort of take it on and say, we should probably think about doing this as well. And I think it's because of these similarities. But the challenges that we face really are very external, and we need these things to be sorted out before we can actually take on anything like, those interventions in terms of policies. I don't know, for a big country like Australia, I think that's, the really bigger factors that I wouldn't be able to advise on. For us, we've really managed, I think, to impact at least government levels on the seriousness of the NCD statistics, the crisis that we're in the Pacific, and that we take up the top 10 countries in the world that have all of the highest risk factors for NCDs, and that includes obesity. So I think those sort of really in-your-face sort of numbers have hit our government people across the Pacific, and I think that's why it's kind of readily been taken on by them.
Thanks, Donald. And it looks like we may have a question from the audience.
Yes. Thank you, Colin. Thank you, Donald, for your wonderful presentation. I'm Rosalyn Botlero. I'm a lecturer at Monash School of Public Health. As a lecturer in chronic disease epidemiology, I know the importance of actually the interventions that you mentioned are very relevant to reduce the burden of obesity. But my question is around, I have a couple of questions. For instance, you mentioned that there is a collaborative policy action between government as well as the consumers, but whether you take into account of the manufacturing companies, especially like the food manufacturing companies which actually produce these unhealthy diets and drinks, as well as transnational like fast food industries like McDonald's, KFC, what's their role actually to reduce this pandemic, and what are the solutions, or what are the challenges and how you're going to address those challenges?
Yeah, thank you very much. I think those are very relevant questions. Just yesterday, or on the drive to the airport on my way here, I saw that we're building a new McDonald's outlet just close to where I live. But I think we're not doing too well in the area of the law and trade and NCDs, and that's probably, I'm not sure if this is sort of shared in developing nations. And I think it's important that we continue to be in the faces of corporates that are going in the opposite direction that we are going in. And so things like not getting Coca-Cola to sponsor events, for instance, I think that's probably the extent to which we're going, and sort of presenting the message or our stance. But because, again, maybe because of the economic level of the country, and ours would be similar to other countries in the Pacific, but I think that's an important point. I probably should just say that we are not doing too well, and I think I think I should be safe in saying that. But thank you for raising that. Yeah, thank you.
Thanks, Donald. And I think we've probably got time for one more question for that session. But please, all of our presenters are around for the rest of the week. So if you don't get the opportunity to ask your question now, they're friendly folk, and they'll be happy to take questions after the session as well. But over to you.
Bula Vinaka, thank you, Dr. Wilson. So, very great presentation. I'm Rosa. I'm from Wanna Connect, Pacific Research and Evaluation firm back in New Zealand. So, where I'm from, in Auckland or South Auckland, obesity rates. I mean, it's high proportion of Māori and Pacific peoples that live in that specific region. Obesity rates, diabetes, all of that, high rates. What we're seeing recently is, childhood, but also youth obesity rates are quite high. The problem is we're not catching it there. So I wanted to touch on the point that you raised about intervention. And if you're seeing, so what we're seeing is we're not catching it at the childhood or the youth stage, because screening is an issue. We're not, we're finding out when they're adults and they're not only having obesity. They don't have obesity. They have, multiple, long-term conditions. So I wanted to just ask, are you also seeing those sort of, challenges in the Pacific or Fiji?
Thanks, Rosa, for that question. The data that I presented, that's almost 10 years old, is particularly between 13 to 15 years old children. I think for those that are between the 5 and 13-year age group, what the Pacific Island countries are currently doing is also standardizing what WHO does in terms of age groups, so less than 5 and then 5 to 15 age groups. That's also happening in the Pacific. But maybe just to say that the Health Promoting Schools initiative is one of the opportunities to monitor children in the primary schools, and so that's from 5 to 15. And also the policy initiatives that are happening, I think in most governments, one is, for instance, the canteen policies, the school canteen policies. These are happening. I don't think that's happening very effectively. There is still the canteen policies, but schools continue to sell junk foods and things like that. So while we are moving forward in terms of policy interventions, there also needs to be a monitoring framework. That is, so who monitors, but then, where is the resourcing of that? I think we're able to identify that those children also need to be, so we need to go much earlier in terms of identification, but it's the resourcing of those initiatives that really need to be looked into, and also the monitoring frameworks and the people who monitor those interventions. I think those are equally important. There was a study, I think, that was done in 5, but these are North Pacific countries, I think, in American Samoa, Marshall Islands, and Guam, including Hawaii. There was a study that was conducted, I think, until 2018, randomized control trial, but that also found that some of the interventions that were done included, things like physical activity, reducing screen time, and looking at diet for children up to the age of 15. It didn't really work out as, a lot. So there was a reduction in terms of weight over the 8 years when the children were monitored. But it's these other things that contribute, these factors that are very important to that initiative that still don't work in the Pacific Islands people. So, yeah, we need to contextualize, but you're right that we need to identify these earlier on. Sorry about the scattered answers, but I hope that kind of answers some of your question.
Thank you for your questions, and please join me in thanking Donald for that excellent presentation. It's now my pleasure to introduce Associate Professor Jaithri Ananthapavan. Jaithri leads the Economics of Obesity team at Deakin Health Economics and the Global Centre for Preventive Health and Nutrition at Deakin University. She's an experienced health economist with over 15 years of experience in both health economics, consulting and academia. Jaithri's research interest is in economic evaluation of preventive health interventions and policies, economic modelling, priority setting, and in methods to better assist decision makers use economic evidence in resource allocation decisions. Thank you, Jaithri.
Thanks, Colin. So today I want to take the next 10 minutes or so to talk about how we can use economic evidence to help make the case for investment in childhood obesity prevention. And I'll be using examples from Australia, Malaysia, and the Philippines. Okay. So just to start, a very brief slide on why economics is important. Oops. So all countries and societies, regardless if you've got small budgets or big budgets, still have a limited amount of resources. And so we need to make decisions about how to actually allocate those resources with the infinite number of demands and wishes of the societies we live in. So economic evidence, or the study of economics, is the study of how to maximise societal welfare with the available resources that we've got as a society. Thanks. Yep. So Honourable Assistant Minister Jed Carney made this point yesterday as well, that healthcare resources, healthcare costs continue to increase. With the chronic disease epidemic, we're spending more and more on healthcare costs. So what decision makers want to know is what they're actually getting for the cost that they accrue. So what are the potential benefits for the healthcare costs that they're spending? And as healthcare costs continue to increase, the amount of money that's actually spent on prevention still is very small. And so what economics can do is actually help us determine how to spend those limited prevention budget to maximise health outcomes, but also to make the case for increased investment in prevention. So there's different types of studies that we can undertake to actually make this case. One of these type of studies are descriptive studies, which talk about or present the evidence on the burden of disease or the cost of illness associated with obesity. And what these studies do is alert decision makers for the need for action. So in some important work undertaken by Professor Alison Hayes and Dr. Vicky Brown, they've looked at the cost of early childhood obesity in Australia. And what Professor Hayes has found is that when you look at the cost of the healthcare use of children by weight status, those with obesity actually cost more than 1.5 times, or you have healthcare costs more than 1.5 times those of children with a healthy weight. And Dr. Vicky Brown has estimated that if you apply it to the current prevalence of obesity in children in Australia between the ages of 2 to 4, it actually costs the Australian healthcare system $17 million. So what this has shown is that there is an incentive for decision makers to act now. Even if you prevent some obesity in children, you do have a financial incentive to to invest now in obesity prevention. But we know that the majority of the costs of obesity actually come when children grow into adults who have overweight and obesity and then have an increased risk of non-communicable diseases. So it's really important to actually show the cost of these non-communicable diseases into the future. And that's what we did in a study led by Professor Marge Moody with WHO and the Ministry of Health in Malaysia, where we estimated the direct healthcare costs and the indirect productivity impacts of select NCDs in Malaysia. We found that the direct cost is about 10 billion Malaysian ringgit each year, with a similar cost for the indirect productivity impacts. But when you actually value the health that's lost from NCDs, the magnitude of impact is just tenfold. So when we presented this evidence to a broad group of government decision makers, the discussion really was that we need to invest in prevention of these NCDs and the prevention of its risk factors such as obesity. However, these type of studies are limited because it doesn't give you any solutions. It doesn't tell you how to actually address this NCD crisis. For this, you need economic evaluations, which are solutions-focused. So economic evaluations provide a comparative analysis of different interventions and present their costs and consequences. And this can assist decision-makers determine whether the cost of implementing an intervention is worth the benefits that it produces. And there are different types of economic evaluations that are appropriate for different decision-making contexts. And the distinction I make here are between single intervention comparisons and multiple intervention comparisons, which we call priority setting studies. So single economic evaluations are useful when you're trying to determine whether a policy will be, if implemented, whether the cost of implementing that policy is worth the benefits that it produces. Whereas if you're trying to actually develop a strategy, and we know that we need a strategy of interventions to impact childhood obesity, what we really need are priority setting studies that look at the cost effectiveness of a suite of interventions that are evaluated using consistent methods, so you can compare them and decide which interventions to include in that strategy. So this is an example of a single economic evaluation. So this was led by Dr. Oliver Hughes for his PhD, where he looked at an economic evaluation of a sugary drinks tax in the Philippines. So a tax was introduced in the Philippines in 2018, and in previous PhD studies of Dr. Hughes, he found that the actual final design of the tax was influenced by the food and beverage industry, impacting the tax rate that was implemented as well as the beverages included. And so what we tried to do is estimate the relative cost effectiveness of the proposed tax compared to the implemented tax. So these are the characteristics of the methods we used. We used the ACE obesity policy model, which has been previously developed, and I'll talk us through a study that we used that developed this model. And we adapted it to the Philippine population, the 2018 population. We compared both the proposed tax and the implemented tax compared to no taxation. And we tracked the costs of implementing that policy, the cost savings and the health impacts over the lifetime of the population. We then quantified the health outcomes as health-adjusted life years gained from the taxation policies. So this is a schematic of the ACE obesity policy model that we used. So what we did was we look at a logic pathway of how a taxation will be implemented in the Philippines context, the costs that are involved in that, and how the tax will actually impact changes in obesity. So the changes in the profile of obesity in the population as a result of the tax is then fed into the model, which changes the epidemiology, the incidence, prevalence, and mortality associated with 9 different diseases that are associated with obesity. This then results in health outcomes and healthcare cost savings. We then combine the healthcare cost savings with the intervention costs to get the net costs, which are divided by the healthcare benefits to give us the incremental cost effectiveness ratio. Determining whether an intervention is cost effective or not will be different in different country contexts. So it's all about how much you're willing to pay for gains in health. And in the Philippines context, one per capita GDP was determined to be the willingness to pay threshold for the health gains. So these are the results, and what you can see is that the proposed tax showed a higher reduction in sugary drinks consumed, which also translated to a higher reduction in weight compared to the implemented tax. If we look at the cost effectiveness results, you'll see that both the implemented tax and the proposed tax are dominant. This means that both of these taxation scenarios both produce health gains as well as cost savings over the lifetime of the population. But what you can see is that the implemented tax has 40% fewer health gains compared to the proposed tax, and around 30% lower taxation revenue compared to the proposed tax. So it can show you the impact of industry on the health and the revenue that could have been realised from the Philippines sugary drinks tax. So this is an example of a single economic evaluation. It tells you whether a sugary drinks tax is worth doing compared to no tax. But if we want to inform a strategy, and we need a strategy for childhood obesity prevention, we need priority setting studies. We need multiple interventions evaluated. And that's what we did in this study called the Assessing Cost Effectiveness of Obesity Prevention Policies in Australia. And the research question for this study was, what are the most effective, cost-effective, affordable, and implementable policy options to prevent obesity across a range of settings? So we looked at 16 different interventions, nutrition policies, physical activity policies, and multi-component policies. And we evaluated the cost effectiveness and presented it in a league table. So this league table shows you the most cost-effective interventions ranked from top to bottom. So here we have the type of policy. So we want to present as much information as possible to decision makers to give them a bit of context around these cost effectiveness results. So here we've got the type of intervention, the actual incremental cost effectiveness ratio, the health gained from these different interventions, the intervention costs, which is really important, and then the net costs. And these negative net costs correspond to the interventions that are dominant. These are interventions that are health producing and cost saving in the long term. And what we can see is all 16 of these interventions are actually cost effective for the Australian setting. Here I've highlighted the 4 interventions that are targeted at children, and we can see that they rank both high, medium, and quite low on the league table. But as I said before, all of these interventions are cost effective. We know that decision makers are interested in more than just the cost effectiveness results. So what we did was we also looked at the broader considerations that might impact implementation of these policies. So the things we considered here are the strength of evidence for the interventions, the acceptability, the equity impact, the feasibility, and the sustainability of the intervention. And I'd just like to show that you can actually present these results also in an implementation considerations league table to provide the range of evidence or information that decision makers might want to see alongside the cost effectiveness of the policies, to provide as much information as they need to make these decisions about a strategy for childhood obesity prevention. So just some key considerations. So I think some of the evidence I've presented today, as well as the body of evidence, shows that we've got enough evidence to take action. And I hope I've demonstrated that economic evidence is really important to consider when making these decisions. There are some key issues that need to be considered when we're looking at improving the cost-effectiveness evidence across Asia-Pacific, and that relates to data. So local data can be challenging to get. So we need to think about how we actually adjust international estimates so that we can make them relevant to the local context. And also think about how to routinely collect the data that's required to build this evidence base. The policies that we talked about, and Donald mentioned as well, that a lot of these policies are outside the health sector. So we really need to consider the intersectoral impacts of our policies and how we actually communicate these impacts across different sectors. Another thing to consider is really understanding the decision-making process and how economic evidence fits in, and really think about in these different contexts, what are the key considerations that we need to present evidence on to help decision makers make these decisions, and what are these other key outcomes of interest that we should be including in our evaluations. For example, environmental impacts might be something that we need to start thinking about. That's my presentation. Thank you.
Thank you, Jayatri. That's fantastic. Any audience questions for Jayatri? Any panel questions? Panel, do you have any questions for Jayatri? I have one if you don't. Jayatri, I was really interested in Ollie's work in the Philippines. Just I think because it quantifies actually what was implemented versus what was planned. That sort of watering down impact that we anticipate happens over a policy implementation process, but that actual quantification part of the process, it's the first time I've seen a piece of work like that. Are you aware of health economics data being used in that way outside of Ollie's work?
Not really. So I was really interested in Ollie's work as well, because it was, so if you did an evaluation just of the implemented tax, it would look like it was excellent value for money, it was dominant. But I think the comparison really helped to show how industry can actually, the losses that you're taking because of industry involvement in making public policy decisions.
Thanks, Jayatri. And it looks like we do have a question from the audience.
Thank you very much for the opportunity. So I'm Rania. I'm a medical doctor from Indonesia, and I'm now studying here in the University of Melbourne. I'm involved in several stunting prevention, like a childhood malnutrition prevention, and usually in some countries that still experience like a double burden of malnutrition, they will focus primarily on the undernutrition rather than the overnutrition, or like obesity or overweight. Because one of your place for research is Philippines and also Malaysia that still experience that double burden of malnutrition. So I'm wondering, like, how do you articulate the importance of focusing on the childhood obesity as well to the government to allocate the funding, and also in terms of the economic aspect, what is the best way to determine the priorities and also allocate the funding between the undernutrition and the obesity in children? Thank you.
Thank you. So in terms of economic modelling, I think, the model is a simplification of reality. So it's hard to incorporate everything, including undernutrition and overnutrition, in the actual economic model. But there's been lots of work done by, so the Lancet Commission led by, there was a study led by Professor Boyd Swinburne, about all the key drivers of undernutrition as well as overweight and climate change are all similar. So I think it's about making the case for action on those key drivers of all these kind of nutrition-related issues. And priority setting is about making decisions and thinking about where you actually spend your money. So actually showing the impact of NCDs and the cost of NCDs, I think, is a good way of getting people on board to understand that you need to really invest in obesity prevention, and that obesity prevention is also good for undernutrition in terms of good nutrition policies.
Thanks, Jyothin. I think we have time for another quick question from the other side of the room.
Thank you. Nicholas Jones from Ministry of Health New Zealand. I just wondered if you could comment on the relative effectiveness of a tax versus a levy in terms of sugar-sweetened beverages.
Yeah, so I think the most effective policies have been in the UK, where they've used a volumetric tax on the sugar content of beverages, and made it tiered so that, you know, it actually encourages industry to reformulate. And these studies have shown that those are effective in both in terms of consumption as well as reformulation from industry.
Thank you. We might need to leave the questions there in the interest of time, but thank you very much, Jyothin. Our next speaker, Alison Feely's provided a video address. Alison is a registered nutritionist from UNICEF East Asia Pacific Regional Office based in Bangkok, where she provides technical support on strengthening policies and programs for overweight and obesity prevention and nutrition in school-aged children. Her previous roles include senior scientist at Public Health England and at the MRC WITS Development Pathways for Health Research Unit in Soweto, Johannesburg, which is also where she completed her PhD on dietary patterns in adolescents. Great if you could please play that presentation now. Thank you.
Good afternoon. My name is Alison Feely. I work as a nutrition specialist at UNICEF's East Asia and Pacific Regional Office based in Bangkok. It is my great pleasure to be able to present to you UNICEF's Preventing Obesity and Improving Diets in Children priority actions to address a growing problem. In the next 15 minutes, I plan to present the extent of the burden of overweight across the East Asia Pacific region, discuss some of the reasons for that, of course, and then discuss UNICEF's approach to overweight and obesity prevention in children. So these two figures here are slightly outdated, but they do show the burden of overweight among children under 5 years of age globally, with the figure on the right showing that the greatest burden in terms of numbers is in East Asia Pacific countries. And in this graph here, we can see that the prevalence of overweight is elevated in all countries in the East Asia Pacific region, with over half of children and adolescents in the Pacific living with overweight. Latest data from the Lancet confirms that the prevalence of obesity has surpassed thinness globally. So there are now higher obesity rates in lower and middle-income countries than high-income countries. And in school-aged children and adolescents, those living with obesity outnumber those who are thin in 2/3 of the countries included in the study. The increases in unhealthy weight gain results from a shift in food consumption, which is driven by the changing food environment. How and where we purchase our food has changed, and of course with those changes has influenced the types of food available in those settings and ultimately what we purchase for consumption. For example, the graph on the left shows the increased numbers of supermarkets and convenience stores in selected countries in East Asia. With Myanmar and Vietnam, there is a 1,200% increase in the number of such stores between 2007, and 2021. And similarly, the graph on the right shows the growth in sales in ultra-processed foods and drinks during the same time points, and Vietnam is showing an increase in sales of around 257% of those products. The changing food environment leads to a change in dietary behaviours and dietary intake. So the graph on the left shows a figure from a systematic review which reviewed consumption levels of sugar-sweetened beverages in children and adolescents in the Southeast Asia and Pacific regions. And on average, young people are drinking over 300 millilitres per day. So in addition to the high consumption of sugar-sweetened beverages, we're witnessing the high consumption of fast foods, as well as the low consumption of fruits and vegetables, with more than half of adolescents in the region not eating their 5 a day, and less than 20% of adolescents are taking adequate exercise. And now I turn to UNICEF's work on prevention of overweight and obesity. In the UNICEF Nutrition Strategy published in 2020, it discusses the approach to combating all forms of malnutrition, which includes overweight and obesity, thinness, stunting, and micronutrient deficiencies. So UNICEF's goal is to protect and promote diets, services, and practices that support optimal nutrition, growth, and development for all children, adolescents, and women. And this goal is aligned to the SDG agenda to ensure children's access to nutritious diets and to end child malnutrition in all its forms. Also, within the nutrition strategy, UNICEF outlines a systems approach to improving nutrition by making 5 key systems better equipped and more accountable for improving nutrition. While national governments have the primary responsibility of upholding children's rights to nutrition, to do this effectively, they need strong, resilient systems that help prevent all forms of malnutrition and deliver timely treatment and care when prevention falls short. The multiple systems as depicted on this diagram include the education system, the health system, the food system, social protection system, and water and sanitation, and they all have a role in making the right to nutrition a reality. A systems approach recognizes then that ending malnutrition in all its forms calls for a shared responsibility to tackle the multiple determinants of child malnutrition. And if we focus in on the food system in red, it highlights a number of priority policy areas, which reflects that in order to prevent overweight and obesity, multiple policies and actions are required across systems. So the areas which UNICEF prioritizes includes front-of-pack nutrition labeling, restriction of the marketing of unhealthy foods and beverages, fiscal policies on unhealthy foods, healthy food retail environments, and of course, UNICEF has always worked on implementing the Code of Breast Milk Substitutes. So in addition to the food system, which I've outlined in the previous slide, I also want to spend a little bit of time on the education system, which UNICEF also prioritizes. Around 2020, we also published a programming guidance which focuses on nutrition in middle childhood and adolescence. And there's a lot of overlap here with the overweight and obesity agenda, but in the school system and beyond. So our priorities in this space are around nutritious foods in schools and beyond. So that includes setting of guidelines and implementing them. Healthy food environments in schools and beyond, and this can relate to protecting against the marketing of junk foods to children within the schools and around schools, as well as micronutrient supplementation and deworming programs. We also work on nutrition education in school curricula, as well as supporting healthy dietary practices of school-aged children and adolescents. In order to carry out these areas of work, we're supported by an implementing strategy which recognizes the need for partnerships, such as obviously those with governments and then also other partners, and resources, including human resources and financial resources. Our programming approaches can include any of the following methods, such as situation analyses, policy, strategy and legislation support, we help to develop frameworks that foster enabling environments for good nutrition, for example. A lot of our work includes advocacy, where we seek to influence those decision makers and other stakeholders who have an interest in food systems, as well as other relevant audiences. We do a lot of capacity development work, which I can talk about in a moment, as well as community engagement. On the right of the slide gives you some examples of some of the documents that we have available on our website, including landscape analysis tools for overweight policies. We've got programming guidance as well as technical briefing papers on legislative measures to protect and improve the food environment for children, as well as documents which have a child rights-based focus. So here is some examples of the evidence generation work that we've been conducting in the East Asia Pacific Regional Office. On the left here is just some snapshots of the landscape analyses we've conducted with several countries to identify key risk factors, evidence gaps and priority action areas for overweight and obesity prevention. So during this process, we conduct a desk review as well as several stakeholder validation workshops to agree to those risk factors and evidence gaps, as well as gaining agreement on priority action areas for the country. And of course, this involves government and other stakeholders. And it is a way of us advocating to get overweight and obesity onto the national agenda. Other areas of work which we commission to support the policy development that we do can include food business data analyses, marketing studies, modelling work such as on sugar tax modelling, as well as nutrient profiling work. We've also commissioned consumer surveys, as well as qualitative lived experience research. And all of this helps to build the case, to build the narrative around the severity of the issues and the need for action. This slide shows examples of our advocacy and social behaviour change work. For example, I've mentioned before that we do a lot of advocacy towards governments, and that can be in the form of our working groups, technical working groups, development of policy briefs and papers, as well as using that research to develop the arguments and narrative on this particular agenda. We are also the technical lead partner for the Association of Southeast Nations, ASEAN, and for the last 3 years UNICEF has been supporting the development of guidelines and minimum standards on a number of nutrition topics, which can include maternal and child feeding. And the latest document that we have supported the launch of is the minimum standards and guidelines on regulatory measures to protect children from the marketing of unhealthy foods and beverages. So we will use the ASEAN documents and systems to advocate further at a country level to support countries in developing their own guidance once these guidelines and minimum standards have been made available. And they can be very useful in advocating at a local level to ensure that either existing policies are strengthened or new policies are developed. In addition to that, we work on private sector engagement, and an example of that current work is around influencing the retail food environments, where we seek to develop guiding principles to support healthier food choices across the region. And shortly, Tailani will be providing insights into that work, which UNICEF is a partner with Deacon on. In addition to that, we're working closely with young people, the youth, since they are the advocates of today and tomorrow. Last year in February, UNICEF East Asia Pacific Office launched a campaign called Fix My Food, which is a multi-country, multi-year campaign which is designed to sensitize youth on the issues of the food environment and how the food environment influences food behaviors and is also a detriment to traditional local foods. We've been facilitating several workshops within specific countries across the region to capacitate youth on their understanding of these issues, and also to see how their advocacy efforts and campaigning potentially can influence the policy agenda within their specific countries. On the left-hand side, there's an image from X to show one of the workshops that we participated in Vietnam recently, and we have partnered with Bite Back, an NGO in the UK, which also supports youth advocacy in order to reduce the burden of overweight and obesity in the UK. And we're hoping that in the next year or two, our advocates will be fully capacitated and skilled in order to develop their own campaigns on this agenda across the region. And we look forward to seeing more of that in the coming 18 months. And this is my last slide. I wanted to share with you the UNICEF East Asia and Pacific Office's website, where you can find a lot of the documents that I shared with you during this presentation. Please go and have a look. It provides technical policy documents and guidance, also some call to action blogs and videos, and it also will link you back to the main UNICEF website, which has additional resources. So with that, I'd like to thank you all for your kind attention, and thank you again to Deakin University for inviting me to share the work that UNICEF is doing on overweight and obesity prevention. Thank you.
I'm grateful to Alison for providing that for us, and it's great to see UNICEF so tuned into the comprehensive strategies that Jyoti was mentioning earlier around childhood obesity and resourcing them at that level. It's now my pleasure to introduce Dr. Tailani Scapin. Tailani is a research fellow within the Global Centre for Preventive Health and Nutrition at Deakin University, and is an early career researcher with the Centre for Research Excellence in Food, Retail Environments for Health, or REFRESH Next Generation as it's known. With a background in nutrition and dietetics, she has experience in researching consumer food behaviours and monitoring retail food environments to encourage healthier choices and promote well-being. Thank you, Tailani.
Thank you, Colin, for the introduction. It's a pleasure to be here today to speak on the work on healthy retail food environment on behalf of the research that we have been doing in GLOBE. And as Alison mentioned in her previous presentation, most of the work I'm going to present today is a result of a partnership project we have with UNICEF in East Asia and Pacific, looking at improving the healthiness of a retail food environment in that region. Before I begin, I just wanted to acknowledge that I have no conflict of interest to disclose in this presentation, and some of the results are still under preparation for publication. I'd like to start by acknowledging the importance of retail food environments for good nutrition and obesity prevention. And as you all know, dietary risks are the leading preventable cause of obesity and non-communicable disease around the world, and that's not different in the Asian and the Pacific region. However, diets are far more than a personal choice. They are influenced by the physical, economical, political, and cultural environment that we all live. And the connection between this macro food system and the other systems that I just mentioned and the individuals is actually the retail food environments, because those are the places that we go when we need to access food. And when I talk about retail food environments, I mean any type of settings that people can buy their foods from. It can include, for example, supermarkets, convenience stores, online supermarkets, but also the more traditional retailers, such as fresh food markets, small food stores, and street food vendors, which, by the way, are very important for the Asian Pacific region. And one of the ways that the food retailers influence our food choices is through their sales strategies of their products. So, for example, the type of product they put on the shelves, how they price those products, how they place these products within the stores, they all have a huge influence on what consumers end up picking from the supermarkets or the grocery stores. And additionally, they use promotional techniques like price discounts to encourage increased purchases of unhealthy foods. And one practical example of this is when we go to a supermarket here in Australia and we can barely resist the temptation of buying junky food because they're all over the place, and especially in the front of the supermarkets with this large yellow tag saying they are on half price. And it's also crucial to note that the government policies also play a significant role in shaping the retail food environments. And we saw from other places around the world that policies such as front-of-package labeling or restrictions on unhealthy foods and all of those policies that Chaitri just mentioned before, they have a big influence on what is available, promoted, and priced through the retail food environment. So in this sense, monitoring retail food environments is important to help us to create the solutions to make them healthier places. And one of the ways that we can use monitoring data to improve the healthiness of a retail food environment is by strengthening the accountability systems with the data that we collect. So by understanding the type of strategies used by retailers and how that changes over time, we can better grasp the influence of these settings on diets and public health. Monitoring data can also help us to hold retailers accountable for their practices and for any commitments that they have made for public health. In addition, we can use monitoring data to support retailers in developing context-specific initiatives to improve the healthiness of their practices. And especially, monitoring benchmarking data have been used before to support the development of government policies for healthy food retail. Because, as you know, most of the time, voluntary commitments from the food industry, they often fall short in driving significant change. So what is happening in the retail food environment in the Asian Pacific region? Our recent analysis showed that change in the food retail sector in this specific region of the world are occurring at a faster pace than in anywhere else in the past 15 years. So, for example, the number of chain food outlets, which includes supermarkets, hypermarkets, and convenience stores, is growing by over 90% annually in South Asia and East Asian Pacific. And at the same time, sales of unhealthy foods are growing by 3.5% each year. And if you look at the graph on the right, you can see a comparison of supermarkets and convenience stores usage by consumers between 2009 and 2023. And in Indonesia, for example, about half of purchases were from chain food stores in 2009, while nowadays it's up to 67%. So just illustrating the importance of these retail settings. And this expansion in the food retail sector and the sales of the unhealthy foods are both really associated with the increased rates of obesity in the region, so they are all growing together. And when it comes to what is inside the stores, we can see from a recent assessment of 68 food outlets in Tongatapu, in Tonga, that unhealthy foods are actually taking over more than 80% of the shelf spaces in both convenience stores and supermarkets. And those type of foods are also the most common ones promoted in premium areas of the stores, like the end of the aisles and the checkout areas. And thanks Sela Fuzi, which is a PhD student from Deakin University, for leading that work in Tonga. We have also conducted in-store assessments in different types of retailers in Thailand, Indonesia, and China, and we are about to start data collection in the Philippines and Malaysia. And what we have been seeing is that our initial findings suggesting that a similar trend that the one occurring in Tonga is also happening in those countries, where unhealthy foods are just floating the shelves and having been heavily promoted to people. And not only the physical retail food environment is changing, but also what we see in the online grocery stores. So, for example, people are buying more foods from these places. And in a sense, in an effort to understand what's happening with the online digital food environment in Asia and the Pacific, we have analyzed the practices of 21 of the largest online supermarket companies across 6 countries. And not surprisingly, we found that what's happening in the physical retail environment is also happening in the digital one, with a lot of unhealthy foods available and promoted through these channels. And this is an example from Indonesia, where we saw that unhealthy foods are frequently receiving discounts. They are prominently displayed all over the retailer's website, and they even have been receiving marketing strategies targeting at children, such as the use of cartoons to promote those products. Under our partnership with UNICEF, we have been developing several strategies to improve the healthiness of retail food environments in the Asia-Pacific and beyond. And this includes developing and publishing a guidance framework to support healthier food environments for children, which have a list of 27 action options for retailers to take to improve their practice towards good nutrition and health. And as Alison mentioned in her presentation, UNICEF country offices are trying to engage with the private sector to support the test and implementation of innovative and evidence-based solutions to improve the healthiness of these food stores in the region. In addition, over the past 3 years, we have managed to create a network of 80 researchers, retailers, policymakers, and NGOs from Asia, all of those interested in improving and transforming retail food environments in this part of the world. And we have been gathering over webinars to discuss and find solutions for this problem. Finally, I wanted to acknowledge that our work is being greatly grounded on the research developed by Refresh, and we are actually now establishing a policy laboratory to support governments in developing, implementing, scaling up, or sustaining policies for healthy retail in Australia and beyond. Thank you so much for listening to me, and I invite you all to visit our websites to further explore the work that I have presented today. Thank you.
Thank you, Tailani. We've probably got time for a question, if anyone has a question they'd like to ask Tailani. No takers. In that case, let's move on to our final presentation for this session, and it's my pleasure to introduce Dr. Jane Martin. Jane has worked in public health advocacy and policy since the mid-1980s, covering risk factors of tobacco, diet, weight, and alcohol. She leads the Food for Health Alliance, a leading advocacy coalition supported by the Cancer Council of Victoria, Globe at Deakin University, and Vic Health, working to reduce diet-related disease. Her role includes strategic advocacy and policy research, agenda for programs, as well as coordinating public education and advocacy campaigns on healthy weight and alcohol use. Jane's career has involved extensive engagement with policy and advocacy-oriented research to advance regulatory reform in the areas of tobacco control, obesity prevention, and alcohol policy. She's experienced in both researching and applying advocacy strategies to encourage all levels of governments to adopt evidence-informed public health policies. Thank you, Jane.
Thank you. Thank you very much for having me. I forgot that I was allowed to be called a doctor when I'm in a Deakin University capacity, so that's a nice little unexpected title. And a lot of what I'm going to talk about today rests on the foundations of the previous speakers. And I hadn't seen Alison Feeney's presentation, but there's quite a lot of synergy with what I'm presenting, so I'm feeling, quite good now. I'd like to acknowledge the traditional owners of the lands that we're meeting on today and pay my respects to elders past, present and emerging, and any First Nations people who are with us today. The Food for Health Alliances is our new branding, which we're really proud of. We're a small group. We were established in 2006, and initially our name was the Obesity Policy Coalition. Colin's already said that we're a collaboration, we're a not-for-profit civil society organisations, and we are developing policy and advocating for improved food environments to prevent diet-related disease. We use the expertise of lawyers, policy experts, dietitian. We really leverage the media and communications as well as research and evaluation. And all these levers play a pivotal role in our work and increasing the political appetite for change. We work very hard to develop policy positions together with collaborators and partners to further our understanding to develop agreed positions. We often share those. Many of you in Australia may have benefited, and New Zealand may have benefited from those. And we use this policy work to engage the media, the public, and to increase support for change. And most importantly, to try and increase political will to support that change. So we advocate directly and indirectly to policymakers, and we focus on the most contested policy areas, and anyone who's been engaged in advocacy knows what they are. They're protecting children from unhealthy food marketing, tax and pricing measures. What causes quite a lot of excitement is a health levy on sugary drinks, which is not such a contested area. And the other day, a shock jock actually said to me it was a no-brainer. So I think the public and the media are certainly starting to shift. We're also calling for clearer labelling of foods and improvement of the nutrition and packaging of foods for babies and toddlers. And really, all the areas we're engaged in are the areas where these commercial industries with vested interests fight back and push back the hardest to prevent regulation. And these are the policies that are most likely to deliver the outcomes that we seek. So these commercial actors, they're powerful vested interests, they're politically powerful, and we've been doing some work around trying to strengthen democracy because that will benefit many of the issues that we are concerned about, alcohol, gambling, these harmful industries. They're economically very powerful, and government has to expend quite a lot of political capital in order to make change and lead in this area. So we know that it's a big commitment that's required to take those steps and take that leadership. I think this is a really good example of the concentration of power to the consumer. It looks like there's lots of different companies and lots of different businesses, but in fact the power is very concentrated. The peak body for the processed food industry in Australia is called the Australian Food and Grocery Council. In one of their recent submissions, this is how they describe themselves, that they have turnover of 133 billion, that they involve 16,000 businesses, they represent 3.2 billion of capital investment, and they employ 272,000 people, 40% in rural and regional areas. It's a very powerful narrative, and it's repeated over and over again. As you know, what's missing from this narrative is the impact that the actions of these commercial actors and corporations have on the health of the community. And that for many, the majority of the products in their portfolios are unhealthy. And an example of that is Nestlé. 70% of products in their Australian portfolio are below 3.5 stars, which is a measure of healthiness of products. And they also neglect to mention the cost and impact of diet-related disease, and most of the cost of diet-related diseases in Australia are borne by the individual and their family, followed by the government. So we really need to be concerned about this as a society. And in Australia, obesity is about to take over tobacco smoking as the leading preventable risk factor for disease in our country. And this is another example of how Nestlé behave globally, exploiting low and middle income countries by presenting different products compared to what they are selling in high income countries. So the key issues for policy success are about developing and advocating the case for prevention, to develop the research and evidence base and help generate that evidence, build consensus, monitor and test legal systems to ensure that the laws that do exist are being applied appropriately, developing shared messaging, communication and framing around the influence of harmful commercial industries, and then building a broader movement, including civil society, and that's something that many of the speakers have spoken about. So I think this is a really important question of who's responsible, and a lot of the narrative in the media talks about individuals being responsible, but government has everybody does have a role to play, but government has not stepped up to play the role that is required of them to improve diets and to reduce diet-related disease. Much of the focus is on individuals, and industry frames it in the same way. And I think, although this is from the Lancet series in 2015, I think it's a really great infographic to demonstrate where does government sit and what role do they play, together with settings and together with individuals. And this was a recent statement before the last election, and I think it goes to what Michael Marmot was talking about, the neoliberal approach. We don't believe in taxing, we don't want to regulate people's lives, we'll give them the information and then they can make a choice. That's very common framing in from our Conservative political party. This is our ex-Prime Minister, Minister for Health. He did famously eat a raw onion once, so it was his fault. I think he thought it was delicious. But we have started to see more of a recognition around the commercial determinants of health, which is pleasing. The current health minister has spoken about reformulation, potentially the Honourable Jed Carney, assistant minister, has also spoken about potentially mandating our front-of-pack labelling scheme. But our National Preventative Health Strategy does speak to the commercial determinants of health. And our National Obesity Strategy, which links down from that, also considers environments, which has been spoken about today, and how important that is. But there are other ways to shape the narrative around the commercial determinants of health. We were involved with a documentary with the ABC, which was hosted by Magda, and who's a well-known comedian, who is living with obesity, and Sandro, and it was a really fantastic way to work with the producers to ensure that the narrative was not just about the individual, but it was about what is happening in our environment that's undermining people's ability to be healthy, and what are these commercial drivers, and who's making a profit here. And it came across in the evaluation that it wasn't just focused on the individual, and I think that's really important to have that narrative out there. This was a very high rating program and really helped to shift the debate, especially after COVID. So it was quite an important agenda setting piece. We've already heard from Alison talking about evidence generation, and Jayatri and the great work of Deakin, and of course Donald's talked about it too. But what we do is we utilise and synthesise existing research. There's a lot of research out there that's not used, and it's really important to go back and see what exists. We work to fill in research gaps, as Alison was talking about evidence generation, particularly in relation to policy-orientated research. And as Jayatri said, we try and think for a decision maker, what will help them make that decision? What information do they need? And often when you meet with a member of parliament or a bureaucrat, often we ask, what do you need to make the case? and you get some really interesting answers and things that you've never thought about. We've worked to create a source of synthesised evidence. This has an Australian focus, but I met someone from Copenhagen the other day who works in government, and they say they use this all the time, and I was very thrilled to hear that, because this was a bit of a passion project, and it did take about 5 years to get it funded and get the idea funded, let alone developed. So I'm really pleased to hear that it's being well used. It's a continuously updated resource, identifying, analysing and synthesising trends in prevention treatment to provide a platform for policy making. We're involved in research alliances. We're doing a lot of work around baby and toddler foods. And this is a piece of work that we've done to look at the Australian food market for babies and toddlers. When we do something like that, we do media, we put out on social media. We've got a lot of attention on this. We do a lot of work working with coalition and shared platforms. We had a really strong message from the Health Minister, Roxanne, when she was developing a strategy on obesity, saying we're not aligned, and that was causing a problem, and it made it difficult for the government to act decisively. So we worked with Deakin to develop a platform of 8 policy actions. We've got a large number of organisations to support, including treatment and prevention and consumer groups. We were front page of the major newspapers. We launched at Monash Hospital, Monash Health, with Helena Teed, who's speaking here today, and it was very effective. But don't forget, there's a lot of organisations out there who are opposing the sorts of issues that we're calling for, particularly a levy on sugary drinks. And again, what was talked about in here was the political and economic power of these agencies. Monitoring is really important. This is some work that's been done by Deakin Informus. We found it really helpful for government to be accountable to best practice. This is a very simple message for a government. These are the 3 things that you need to do. This is where you're falling behind. And we also test consumer law. This was a product that was nearly 69% sugar, marketed as healthy for children, nutritious for children, and Heinz was fined $2.25 million. Had a chilling effect. The product were taken off the shelves, but there's plenty of products similar to this still being marketed to children. Communication and framing is really important. Vic Health has put a lot of investment into this. Don't talk about the nanny state. I mean, I think nannies look after children, but stay away from that debate. Don't tap into responsibility and choice. That puts it back on the individual. Highlight what the barriers that people are facing to be healthy, and frame health promotion as a social justice issue. This is bite back again, but I really love the framing that they're using. Fuel us, don't fool us. And about how we are surrounded by junk food. It's bombarding us. And this is a generation fighting back. So I wasn't aware that UNICEF were working in this space. But I think it's a really great way to give a voice to youth, but the framing is really well done. Lived experience is very important. In Australia, we have the Weight Issues Network. It's not funded by pharmaceutical, very unusual, and helping to fight stigma, particularly in media, as well as with health professionals, and to give people living with obesity and their families support and a voice. And it's a fantastic network. We also have the Parents' Voice, which is paused at the moment, but that's the voice of parents, because there's a lot of focus put on the role and responsibilities of parents. I'm going to finish with an ad, a mass media campaign. I'm not showing it because it supported behaviour change. I'm showing it because it had other effects. And I'll just play that. Do I have to push something?
Sports drink, fruit drink, energy drink or soft drink. The sugar in any sugary drink is sugar your body doesn't need, so it gets turned into fat, including toxic fat, which can lead to cancer, type 2 diabetes and heart disease. Breaking a sugary drinks habit won't just reduce fat around your waist, it will reduce toxic fat around your vital organs.
So the interesting thing about this campaign was there was behaviour change, particularly amongst high consumers of sugary drinks, but it also increased support for a health levy on sugary drinks. And I think that's Bloomberg's used those sorts of strategies to soften the ground for policy reform. So I think these sorts of approaches will help to influence a policy agenda by favourable media attention, building public support, which is already very high in Australia, building political party support, resulting in leadership and action by governments. Thank you very much.
Thank you, Jane. Is there anyone have a question that they'd like to direct to Jane? Lunch is calling. Jane, a quick one from me. How important? You guys do a wonderful job of leaning on the food industry in the media. I think we're really spoilt to have you guys to be able to do that. How important is it? Do you think that's a really critical role for countries to have an organisation that's independent and able to do that?
Yeah, I think it's really critical. I mean, one of the points I was going to make was how important it is to fund this kind of work. The Cancer Council initiated with others our alliance because of the work that had been done, the leadership they'd shown in tobacco control, so understanding that you need to have that. And that's where I worked when I first left university at ASH Australia. So those kinds of organisations that can help to funnel those concerns, to amplify research, to help set the research agenda as well and contribute to knowledge translation and advocacy outside of the research environment, I think is a really important element. Research, and a lot of researchers don't want to do the advocacy. It's not something they're comfortable with, or they don't have the networks to be able to do that. I think it's changing, but I still think that we can provide a lot of that support and engagement in research collaborations, but also have a voice around what the solutions are required for the media when these conversations are happening.
Thanks, Jane. Can I encourage you to join us in room 219 upstairs after lunch, where there'll be a session titled "A Call for Community and Corporate Action on Obesity." And just as a session wrap, can you please, firstly, thank you for your engagement with us in this session. It's been a really interesting session, and please join me in thanking our wonderful speakers this morning.